Good morning, everyone. I'm Greg Dorn, and I'm pleased to welcome you to the expert panel in the field of population health. Today, we will be awarding the Hearst Health Prize in Population Health. This is a $100,000 prize that's awarded to the best program across the nation of many, many applicants that has improved the health of a population. We've been doing this prize for about 5 years, and we've been in partnership with Dr. Nash and the Thomas Jefferson School of Population Health. For this panel, what you'll get is you'll get the last 4 years of winners who will come on and they'll share their experience of working in population health. They'll tell us what they've learned, what they've seen since they've won the prize, and how they've been able to implement additional programs and insights. So I think you're going to take away some great learnings. I'm delighted to have Dr. Nash, David Nash, join us on that panel. He's the Dean of the Population Health School at Thomas Jefferson University, and he's been a great friend and a great mentor and a great leader in this field. What is your biggest takeaway from the Hearst Health Prize program as our partner in this program? You've evaluated so many of these population health programs. If you had to distill it all down and come up with a gestalt for our audience and our learning students and so on, what would that be with regards to your perspective over the last 5 years of population and population health and the prize and the entrance?
What have I learned in the last 5 years? Well, I have just been literally blown away by the scope, the depth, the quality, the commitment on the part of all the applicants. Our previous winners are a testimony to their commitment about going upstream to shut the faucet rather than constantly mopping up the floor, a commitment to great measures to demonstrate without a doubt the improvement that they've made in the health of very distinct populations. In a way, colleagues, the last 5 years in particular has been sort of a window on the world of population health, meaning looking through the lens, through the window of the Hearst Health Prize, we've seen the growth in the number of applications, the scope, the need, and of course, in the post-pandemic world, boy, I think this prize is more important than ever before. So personally, I'm grateful for the support of Hearst Health, for all of the companies, for the leaders like Dr. Greg Dorn and others. I'm especially grateful to the now hundreds of applicants from across the country, and it's such a personal privilege for me and for all of the judges to have the opportunity to review these applications from all across our great country.
Tom, thank you for joining us and representing Community Care of North Carolina. You know, when we did the first Hearst Health Prize, you all won that prize because we believe that transitions of care for individuals are so incredibly important, and it's even becoming more important now as our populations age and as people move from acute to other venues. Managing those transitions has a huge impact. But since that time that you've won the prize, what are the hallmarks that you would want to share with our audience about the use of a transitional care program and technology? How has Community Care of North Carolina utilized technology to make transitions of care more effective and safer and better for the people who are moving from venue to venue to venue?
Thanks, Greg. So I think for anyone rolling out a transitional care program, you're going to work intimately with your healthcare ecosystem. And for us in North Carolina, we had this great collaboration with many of the hospitals where we were receiving ADT feeds. So back when we won the Hearst Health Prize in 2016, we were receiving feeds from about 80% of the hospitals, and now we're well past 90%, and we get feeds sometimes 3 times a day. So what we're doing is matching our predictive analytics on those high-risk patients with the timely ADT feeds to start the transitional care work. And I think what's been so great to look back since 2016 is now we're pushing those tools out into medical homes. So as you know, many medical homes are starting to work with transitional care codes, with Medicare, and with other value-based programs. And now in the Medicaid space, we're showing them when their patients are in the hospital and which ones they should use their care team to reach out to enable them to transition out of the hospital and reach their care goals and health outcomes.
Thank you for that incredibly insightful answer, and I know that all of our audience participants have learned something from your response. Can you also discuss how Community Care of North Carolina's experiences with the effective targeting of patients for interventions? We hear so much about this, that we need to identify what people need, the right intervention at the right time for the right patient, and maybe we can do that in circumscribed venues, but doing that across a continuum of care, doing that in transitions is really almost the next level of population health management and improving vulnerable populations. Can you tell us about how you were able to do that and how you were able to focus on health trajectories and reduce costs and improve quality and reduce the reliability on very high cost venues like emergency rooms?
One of the things that's been so interesting, again, looking back to 2016, is since then we've had the randomized controlled trial from the Tandem Coalition hotspotting, and Community Care has really been able to compare its approach to what happened in that randomized controlled trial. And what we've really thought about is how we're really picking needles in a haystack across this risk continuum. And what's been so interesting in our evaluation is the persistence of the effects after doing transitional care. So, for example, when we do transitional care with a high-risk individual, and there's intensive work for 30 days, sometimes 60 days, that effect lasts over 12 months. And so we show a 20% risk reduction of readmission even after 12 months. So if you're used to looking at survival curves, we're showing a survival curve that comes out over a long period of time. A lot of this has to do with connecting individuals with the medical home at transition. So you need to get people connected closely to primary care, to specialty care often, to pharmacy care. You need to make sure medication adherence and those new medications are being taken. And then often in the Medicaid space, folks with behavioral health problems, substance use disorder, we're needing to connect them to those resources as well. So you're bringing all these resources to bear in that first 30 to 60 days, but that effect seems to last over a long period of time.
Brenda, it's great to see you since we were together in Salt Lake.
Hi, Greg. Happy to be here and still be moving this initiative forward with you. And let's keep working on it.
Your program of integrating mental health screening into primary care has really been demonstrated to be groundbreaking. We have always, unfortunately, compartmentalized those two types of care, traditional care and mental health care, and you demonstrated that they could be put together into the workflow for significant benefits. People coming in for primary care would be screened for basic mental health issues, which commingled with their disease process. And you were able to show that through screening and the identification of these mental health comorbidities, you could drive much better outcomes. So with that backdrop, tell us, how has the mental health integration program evolved since you won the Hearst Health Prize? How have best practices and expertise in mental health integration been disseminated, and how has that program expanded?
Thank you very much for having me participate in this panel. I'm excited to speak about how the Hearst Health Prize has really incentivized the best practices and the teams at Intermountain that built mental health integration and integrated team-based care. And what I would like to start with is to really give credit to the culture that was already existing at Intermountain before we actually even built the mental health integration program. And that Intermountain has really been dedicated to really helping people live the healthiest lives possible, and has a culture of self-study, a culture of building teams around clinical and operational work processes, and a robust data system and outcomes measurement to be able to track that there's actually been an impact. So that foundation was there when Intermountain's leaders began to listen to their primary care physicians and primary care teams that were having difficulty implementing quality around diabetes and asthma and other chronic conditions because of the significant mental health and social burden that they were dealing with in terms of anxiety, depression, domestic violence, substance use, all the issues you hear now that are still of great concern to our country in terms of mental health. And Intermountain's leaders had a foundation and a culture to really address building a mental health integration and team-based care process that really focused on whole person care. So we went down the journey of building a team-based care process model. And then in 2016, after we had disseminated the best practice within Intermountain's primary care and medical group from 1 clinic to 2 clinics to 7 to 25, and now it's disseminated in over 185 clinics across our medical group. In 2016, we were able to publish, with Intermountain's great commitment to data and robust empirical evidence, the impact that this integrated team-based care was having on both quality and cost. So the JAMA study was published just prior to the Hearst Health Prize. And both of those events culminating together, what I really would like to share with Hearst Health, and thank you for, is it really gave our physicians and our nurses and our patients and families, all the folks at the front line that had put the effort into transforming practice, which is very difficult to do, it really gave them a really good sense of being recognized and rewarded for their hard work. They felt that they had really contributed something really excellent and meaningful to not only Intermountain, but to the country, and that people were looking to us to come help disseminate this even further beyond Intermountain.
Thank you for that incredible answer. And I hope that more clinical health centers and more primary care doctors and large practices and academic medical centers and folks who are focused on population health really look at your program and how to integrate mental health into the primary care work stream. But with that being said, tell us, today with the pandemic, people being isolated because of COVID-19, we have heard about mental health issues. How are you seeing mental health care evolve as a consequence of COVID-19? Is your program being integrated into the care still with those primary care physicians? Is it being integrated in potentially a telehealth manner, as we all can't always go see our physician? Tell us about how the program has evolved in the setting of this national or global pandemic.
Excellent question, very timely and very urgent. Mental health and the economy will be the top 2 issues that will be with us for a very, very long time. And the pandemic has exposed the fragmentation of our siloed healthcare system, but most explicitly within primary care. Primary care over the years has been built to really provide continuous, trusting relationships for people to go and get their healthcare needs met and understood, and have someone that really understands and treats them as a whole person. And as we have become more specialized and we are operating within a healthcare system that treats health as a commodity and not as a public good or something that everyone should have, similar to education, it has really exposed some tremendous failures in terms of access and equity. And I see that mental health integration and integrated team-based care is an evidence method that's already proven, not just by Intermountain, but many places across the country, that has good evidence that if we integrated mental health and social needs as a routine part of primary care, this should be available to every single person. And it should be available not just within the medical clinic, but it should be available to them virtually and through telehealth and through all the technology that's available to do that. And people just do not know where to go and what to trust. And there are multiple mental health solutions that are not adequate, but there are also many mental health solutions that would be adequate if we could integrate them into an organized clinical process by which it was actually measuring and contributing to showing that outcomes got better and people could see that they were actually improving, or they actually were getting connected up to the services that they needed. So I see the COVID-19 as urgent and also as an incredible opportunity because no one is free from the exposure of the virus. And no one is free from the exposure of mental health and social issues that are facing this country. And we have methods and we have ways to be able to address it and reach out and improve the structures around people and populations and communities. And it's time for us to do that together in partnership with our communities.
Joe, thank you for joining us on the population health panel here. You know, homelessness has been in the headlines across our nations and none less than the West Coast. And I think what you've done in Massachusetts is groundbreaking. It's record setting in how you have transformed homelessness services across the state to improve outcomes, to really take people and get to them where they are, and also turn the model on its head. Instead of having lots of criteria for people accessing services as homeless, to say we provide certain services and then we move on to improving. So what can you tell us about the Home and Healthy for Good program and how it's evolved over the years? It was groundbreaking a few years ago. It's a model for what we should be doing, in my opinion, in other big cities on the West Coast, particularly where I live in San Francisco, and before that, Los Angeles. So tell us, how's the program evolved?
Well, thanks, Greg. It's great to be here. And again, Home and Healthy for Good started out actually as a pilot that was trying to show the value added that permanent supportive housing could bring to the homeless individuals impacted, but who are experiencing homelessness, but also to the healthcare system in terms of utilization of care. I think aside from the 1,200 people, over 1,200 people who've been housed, I think one of the positive evolutions that's taken place recently is that it's become kind of a regular funding source for people who are actually trying to create new units of permanent supportive housing. Greg, we're very excited by the fact that the Worcester Housing Authority actually is utilizing Home and Healthy for Good funds with a new project of 25 micro units in the city of Worcester. And the funding is so flexible. What really works well with it is the fact they can utilize it now for some of their capital costs, some of their development costs, and then after the property is up and running, retain that as an operational resource or as a service resource. It's flexible, it's up to them. And so I think that the real evolution of this has been the shift from it being a pilot to being a reliable source that homeless service providers can utilize and to leverage other resources to develop permanent supportive housing.
Thank you for that insightful answer, and I'm hopeful that our leaders across the country will take your advice and your insights. One of the other things that we observed that you did that was amazing is you were able to organize agencies and resources and centralize them to be more efficiently deployed. How did you do that? How did you forge these effective partnerships to bring stakeholders together who in some cases may want to run their own little program, but you were able to bring them together across the state and fund them and make the allocation of resources much more efficient and effective? How did you do that? And what could we learn from what you did in other parts of the country?
Well, Greg, I think that really is probably the most important part of this program. And it really grows out of the fact that the Massachusetts Housing and Shelter Alliance, in and of itself, really is a collaborative of member agencies. And so it becomes a really effective way of disseminating innovative concepts or ideas. And it also becomes a way of having some type of collective impact related to a specific type of innovation like Home and Healthy for Good. Home and Healthy for Good really represented the first attempt at really providing low barrier housing for chronic homeless persons and also for medically complex long-term homeless or people experiencing homelessness as one of the first real attempts at trying to provide non-compliance-based low threshold housing to people who are experiencing chronic homeless or to people with complex medical issues experiencing long-term homelessness. Was it really gave a great platform for providers to take the risk. In other words, for them to be able to come together and discuss and talk about the various case management models or service models that they were trying to implement, so that the collaborative part of this became easy because of the value that it added to each of these individual agencies. You know, it's funny because when we first started Home and Healthy for Good, we really didn't have a name for what this was, but we've since learned to discover that what we're really talking about are forming learning collaboratives. And that's exactly what Home and Healthy for Good represented. And so it became reciprocal in a way, because it wasn't just the individual agency that was benefiting, but it was the Massachusetts Housing and Shelter Alliance that was benefiting. It was the other agencies that were benefiting, all from their participation in this type of common effort. All people trying to do the same thing with the same result, committed to measuring data and taking a look at whether what they were doing actually worked. So again, it's really a part of the long tradition at the Massachusetts Housing and Shelter Alliance to be everything we do is collaborative. We're not a service provider per se, and so that puts us in a good position to be the intermediary, to be the resource, to be that entity that can create a platform out of which all of them can work together.
So our panelist, Suzi Johnson at Sharp, developed an incredible program in transitions of care. And this is helping people move from facility-based care at their end of life into the home and allowing them to get thoughtful and gentle and caring palliative care at home. It's a one-of-a-kind program that's been done at Sharp, and I think it's an example of how we can do more for people in the home versus in facilities, and that people prefer to be cared for in the home. And I think Suzi Johnson is a groundbreaker in doing this kind of work in palliative care, and that's why last year she won the Hearst Health Population Prize. So please, Suzi, welcome to the panel. And please tell us a little bit about how did the Sharp Transitions Program evolve since you've won the Hearst Health Prize? What's happened since you won the prize last year?
Since winning the Hearst Health Prize in 2019, the Sharp Transitions Program has been focusing on how to expand the dementia program in particular to a care pathway starting with prevention all the way through end-of-life care. So the Transitions Program, Dementia Program in particular, started out looking at how we could manage people who were in late-stage dementia. And through our efforts over the last year, we have developed additional tools and resources to help physicians and specialists think about early assessment in terms of prevention of dementia, and doing things like adding an assessment tool into the electronic health record for physicians, teaching them about ICD-10 coding activities, creating additional tools and resources to help them not only assess their patients, but to prepare patients for things like anticholinergic burden scores, high-risk medications in the elderly, polypharmacy, pre-surgical risk assessment, and how to prevent dementia and delirium, actually, if a person decides to have a surgery. So this has become a very big focus for us at Sharp, because we know that if we can help prevent dementia, we will improve the quality of life for people for quite a long time. Now, for people who have early onset dementia or early stage dementia, we've also created tools and resources to help our providers and our patients and families be able to manage longer living at home safely. So things like caregiver support, training our social workers and our other healthcare providers on how to help support patients with dementia and their families, getting them into programs like the Alzheimer's Association, additional caregiver support resources, has really helped advance the way in which we're thinking about a chronic illness once somebody actually is diagnosed with it.
Thank you for that incredibly insightful answer, Suzi. I have one more question for you. What's your perspective on the growth in the interest of home-based care in the past few years? We've seen some of it, but we'd love to hear what Sharp Transitions is seeing and how it's succeeding, or maybe even where you've struggled with people thinking and adopting home-based care? Just how are people becoming open, or what are some of the concerns around home-based care?
Early on, we recognized that if we could help people stay home and avoid a hospitalization or an emergency room visit altogether, that could be a game changer for how patients and families live a high quality life. So our program was really built more on a social model and less on a medical model. And I think that is really one of the tenets of our success, is built on that model, that there is not a requirement for medical necessity to be in the transitions program, nor is there a need to be homebound. You don't have to have a skilled need. There does not have to be medical necessity. We're looking at ways in which we transition out of the medical model into a more comprehensive model, of which the medical model is a part but not the driver. I believe that our success is very much built on that model, in addition to using many of the precepts of hospice care in terms of interdisciplinary care, using an interdisciplinary team, nursing, social work, spiritual care, a physician. We've included pharmacy, integrative therapies, volunteers, etc., into our program so far upstream, believing that people can do better staying in their own home. That is really why we've been so successful.
I want to thank each of the panelists for joining me today on this Hearst Health Prize panel. I think all of us can tell that they're groundbreaking leaders in the field of population health, and we can still learn a lot from them. We're going to be awarding the prize a little bit later on, and we hope you can all join us. It's going to be another great outcome for population health. And with that, stay tuned to the Hearst Health Prize. We're going to continue to award it every year as we continue to focus on improving population health, the science behind population health, such that we can develop best practices, methodologies, and approaches that improve care across the continuum and across this entire nation, and hopefully globally. So again, thank you for joining me on this panel, this Hearst Health Prize winning panel.